All right. Good morning, everyone. Welcome to Ocular Pathology Rounds. Ooh.
We've never had that happen before. It was fascinating.
We shouldn't let other people record, should we?
Exactly. Just go. Fine.
Sorry, Kelsey. It's available on YouTube, or it will be shortly after this. Okay. Alrighty, so welcome. If I was really clever like Megan, I would have like an April Fool's thing, but I don't. So no fooling, it's time to get started.
Hey.
All right. The first case, hello, this is Gillian Shaw. I'm one of the pathologists here in Coplow. The first case that I will present is a dog, and it is a 5-year-old hound mix who had been adopted about 8 months previously, prior to the enucleation. So at that time, the left eye was noted to have a milky white film over it, but the pupil was still visible. I'm not sure exactly what they meant by that. And they say the eye would display waxing and waning redness and discharge. And blah, blah, blah. In December, which was about a month prior to enucleation, the left eye became progressively red and uncomfortable. Roughly, oh yeah, so that was a bit of irrelevant history, which I won't share. A red herring, if you will. So here is the globe. When we received it, there was a really obvious sort of more opaque area of the peripheral cornea in this area. So we sectioned it to sample that. And if you follow the cornea along here, all of a sudden it's discontinuous, and same with the sclera. So there is a rupture site here, or a perforation site. The inside of the eye contains a lot of white material, which is exudate or suppurative, probably fibrinosuppurative exudate, so neutrophils, fibrin, etc. There's also a little bit of hemorrhage. One of the things you may notice is that the lens is not very obvious here, so it's not terribly apparent. However, this dark line right here, I believe, is the lens capsule, so we can look at that at under magnification to confirm. The retina is back here. It seems to be in place, and the optic nerve is here and seems to be okay. It's a little bit cloudy, I think, because of what's going on in the vitreous. The vitreous is a little bit cloudy as well. And they said no glaucoma, so we would not necessarily expect optic nerve head atrophy in this eye. We felt it was a little bit, well, anyway, okay, so those are the main gross findings. So now we will continue to our histology. So we'll do the subgross here. So the cornea is to the left here. Here is that defect. So you can see that once again, the cornea is here, and then it's discontinuous, as is the sclera. And we have a whole bunch of cells here. So as usual, we always have to decide whether we're looking at something that's neoplastic versus inflammatory, reactive, or whatever. I already sort of spilled the beans that this is an exudate, so this is an inflammatory exudate. So it's pretty intense right there at that perforation site. As we move back, here's our iris on this side of the eye, and here's a part of the lens. So we have a little bit of lens fibers left. The lens capsule is totally discontinuous, and the entire lens is discontinuous across the pupil. As we carry on over here, it's more of the same. So we have more significant anterior chamber inflammation, as well as posterior chamber inflammation. And then the iris itself also has some darker purple areas. So those are areas of inflammation. And as we move back, it actually looks relatively okay back here. The vitreous has a little bit of increased protein, which is what gave it that cloudy appearance grossly. And then we have a little bit of hemorrhage, so that corroborates the hemorrhage that we saw grossly as well. We have one little, a couple foci of inflammation in the retina and the optic nerve, but the optic nerve itself doesn't look too bad. This is artifactual retinal separation, which occurs commonly with fixation and processing. Okay, so now we're going to go ahead and look at what we have here. So we're going to start over here in this defect. So we're going to try and pick it up over here. So over here we have the ciliary body plica and the ciliary body stroma up against the sclera there. And then the iris base is here. So that's sort of separated from the sclera. So there's a bit of cyclodialysis here. That's what we call it when the ciliary body is separated from the sclera. And I don't see any evidence of peripheral Descemet's membrane. I'm not sure exactly where it is. Huh?
I think it's in exudate.
Oh, yep, there we go. Jamie pointed out. Here it is. Here's the end of Descemet's membrane. It's all curled up and multifocally discontinuous. And as we look at the surface here, we have our surface epithelium on the surface, which is where it should be. And then we also have islands of epithelium in what would be the stroma of the cornea. So we have epithelial sort of islands in the what should be the corneal stroma, and they're surrounded by significant inflammation. So let's just take a look at what kind of inflammation we have here. We have a couple of different cell types here. So most of what we have are these larger cells with large nuclei and sort of finely dispersed chromatin and single nucleoli. These are macrophages, and they're all over the place. They can be spindle-shaped, they can be polygonal, they can be stellate-shaped, but that's what we're looking at there. And then we also have a large number of plasma cells. So here's a plasma cell with its little perinuclear clear zone. There's another one over here. And then we also have some neutrophils, so all these little squiggly nuclei are the neutrophils. And probably in here, we probably have lymphocytes somewhere too, but fewer lymphocytes. So we have heavily histiocytic or macrophage-rich neutrophilic inflammation, so we can call that pyogranulomatous. We also have evidence of chronicity with plasma cells. Whenever you see those cells around, that usually means it's, the inflammation has been going on for a while. I did not see any microorganisms, sorry, in this inflammation here. And as I said, it was surrounding these islands of epithelium. And as we carry our journey, as we continue our journey into the eye, here's Descemet's membrane, so it's all squiggled up and it's discontinuous. So there's Descemet's membrane rupture. And then we are basically in the anterior chamber here. I'll just zoom out to show you. So this is the iris, and here's the anterior chamber. And actually what we have here is a layer of epithelium, corneal epithelium, lining sort of the back of what would have been the cornea. So, fun fact, the inside of the eye really hates to have surface epithelium in it. In part because surface epithelium is typically stratified squamous epithelium, and it sheds epithelial cells into the anterior chamber, and that's really bad. Keratin and keratinized cells, especially when degenerate, incite really intense inflammation if they're in a tissue. So, for example, this is sort of inside the eye, and it's inciting this really intense inflammation, probably in the corneal, what used to be the cornea, as well as the anterior chamber as it's shedding keratinocytes off into the anterior chamber. Another example is when you have any kind of hair follicle rupture, and then you have keratin that's sort of freely in the dermis, that incites like really intense inflammation in the skin. But anyway, so this helps to explain some of the reason why we have such intense inflammation in the front of this eye. And you can see that that inflammation really is very intense. It's lining the back of the cornea here. And Descemet's membrane, here's more of Descemet's membrane. So it's broadly separated from the deep corneal stroma, and then we have that inflammation just kind of all over the place. It's very likely that we have more of the surface epithelium around in the anterior chamber, and it's just harder to identify when it's not so beautifully stratified the way it was in that one area. So now we're going to focus a little bit more on what's going on in the anterior uvea. So here we are in the iris. And we have really thick fibrovascular tissue that's also heavily inflamed. So we see these little blood vessels here. So this is an indication that there's fibrovascular membrane formation on the surface of the iris. And so it's actually sort of hard to tell where that starts and the iris begins or ends or whatever. And then in the iris stroma, we have really intense inflammation as well. In this case, we have quite a few plasma cells once again, and then also lymphocytes. So a lot of these smaller cells, like this guy, this guy, and this guy, are all going to be lymphocytes, whereas we also have a lot of plasma cells. There's a little bit of hemorrhage here in the stroma as well. These are extravasated red blood cells. Um, so we're going to move in. So not only do we, the surface epithelium that has crawled into the eye through that defect provides one very good reason for the intense inflammation. The other great reason that we have for the intense inflammation is that the lens capsule is completely ruptured. There's almost no lens material remaining except for the equator of the lens. And what we have is lens fiber degeneration, not surprising when the lens capsule has ruptured. And we have a lot of inflammatory cells mingling with the liquefied lens fibers. So we have a bunch of neutrophils here. And then what we have here, these are degenerate lens fibers. We call those Morgagnian globules. Also in this lens, I'm gonna have to zoom out to find it. Right here. So we have these sort of vaguely more purple areas or purple hue to the liquefied lens fibers. And when we go higher mag, it starts to take on more of a granular appearance. Dun dun dun. So what we have here are intralenticular bacteria, and I know it's a little bit fuzzy. So these are small cocci. Oh, it looks better in the scope. But anyway, these are so intralenticular, so inside the lens, these are cocci. So the way this happens is some sort of trauma occurs, a penetrating trauma that's contaminated. It enters the eye either through the sclera or through the cornea, and then pokes the lens and deposits a little bit of bacteria in the lens, and then those bacteria sort of wake up and go, "Ooh, we're going to start proliferating." And so they start proliferating inside the lens, and they incite really intense inflammation, as well as probably contribute to the degeneration of the lens fibers themselves. So I've already spilled the beans there. We have pretty good evidence that there was some sort of penetrating trauma to this eye that was contaminated with bacteria that probably caused this defect in the peripheral cornea here, as well as cause lens capsule rupture. And as I said, the back of the eye is pretty quiet, so we're not going to spend much time on it. So the most common reason that we know of for this set of lesions is a cat scratch. So remember that this dog was adopted 5 months prior, or sorry, did I say 9 months prior, or something like that, with an abnormal eye. So we actually don't know what happened to her eye. But we suspect that there was some sort of contaminated penetrating trauma, which more often than not, we blame the cat on. Blame on the cat, I should say. However, it could also be like running into a very sharp, long plant thorn of some sort or some other sort of trauma like that. So let's go back to our PowerPoint. So lens capsule rupture with suppurative phakitis, that means inflammation inside the lens. Intralenticular bacteria and hypermature cataract consistent with what we call septic implantation syndrome, which essentially means that there is lens capsule, well, there's a very lens-centric inflammatory process. In this case, we also have this really extensive ventral limbal sort of peripheral corneal stromal defect with anterior chamber extension of surface epithelium, which I really feel caused a lot of that really intense inflammation inside the anterior chamber in this case. Usually in cases of septic implantation syndrome, the inflammation is centered right around the lens and sort of the back of the iris, and it doesn't necessarily spill into the anterior chamber the way it did in this case. And then we also have a severe pyogranulomatous and lymphoplasmacytic anterior uveitis and endophthalmitis. So those are the main features of this case. I thought it was interesting that that anterior chamber extension of the surface epithelium, I think, intensified the inflammation that we saw. Interestingly enough, we have cases of septic implantation syndrome that, a witnessed cat incident was months prior, sometimes even a year prior. And like there will be intense inflammation at the time of the injury, and then they'll treat it medically and it will quiet down. And then some number of months later, the eye just explodes with inflammation again. And we think that corresponds with the bacteria reaching a certain threshold and or leaking out into the rest of the eye and inciting really intense inflammation or something like that. And or the lens material itself degenerates to a point that it starts leaking into the eye, and the eye also really doesn't like lens material, and it incites intense inflammation. So there can be quite a gap in time between the cat incident and the inflammation, like when the eye actually sort of explodes with really intense inflammation. All right, moving on. Next case is, are there any questions about that? Next case is a 13-year-old neutered male mixed breed dog. They say corneal perforation, and that's the only history we got. So, as we look at the gross photo, we can tell that it's a lot more complicated than that. So here's the cornea at the top, which is kind of hard to tell. Here's the lens, which is kind of displaced, and it's cataractous because it's opaque. And then we have this off-white tissue that's inside the eye, perhaps within the uvea on this side of the eye. And really the cornea itself is quite opaque. And then maybe some similar material is down in here in the choroid. So we have to decide, once again, is this inflammatory or is this neoplasm? The other thing to note in this eye is that there's not a whole lot of melanin pigment around. So we have a little bit of melanin pigment up here, and maybe up in this area. So this is suggestive of this being a blue eye. So with that in mind, let's go ahead and look at what we have. All right, so cornea is to the left here. There is a defect in the cornea. So you can kind of appreciate this is corneal stroma, and then all of a sudden it's kind of discontinuous and it kind of bulges outward there. So we do have a corneal perforation. So the history was correct in that aspect. And then here's our cataractus lens that is sort of displaced. The iris is kind of hard to identify on this side of the eye and on this side of the eye, although we do have this line of melanin pigment here. So that might be some of the iris epithelium, which is on the back of the iris. And then we have this tissue, which from this magnification is kind of hard to tell what exactly it is. We do have some areas that are slightly more purple and some areas that are more pink. The more pink areas are necrosis. So there's necrosis of whatever tissue this is. And then we have more of that tissue on the other side of the eye. And then it's also in the cornea as well, which is sort of interesting. And then back here, here's our optic nerve, and the choroid is a little bit expanded as well. So here's the third eyelid, which is not necessary for making a great diagnosis in this case. So let's go ahead and go high and mag. So yeah, we do have a corneal defect. I'm not going to dwell on that in this case. I think that's probably due to ophthalmos, glaucoma-related exposure, et cetera, et cetera. When we start looking at this tissue that was on this side of the eye at lower mag, we can start to pick up some interesting patterns. So we have some areas where we have cells sort of lining up along these sort of accumulations of pink stuff. And then in other areas, like over here to the right, we have really sort of cells arranged in what we call bundles and streams. So this is a neoplasm, and it has some unique features. The cells are spindle-shaped, which generally implies that this is a mesenchymal cell population, as opposed to epithelial or a round cell. They have fibrillar eosinophilic cytoplasm and some nuclear features with some coarsely clumped chromatin, perhaps, and some variably prominent nuclei. And there are mitotic figures around. I think this is one is right here. So, and then this unique growth pattern here is characteristic of nerve sheath tumors. Hopefully I got that right. Um, and so this is Antony A or B. I can't remember which pattern we call this. Is it A? A. Antony A. And so this is a less cellular area of this neoplasm compared to the Antony B, which tends to be more densely cellular. And then this fibrillar material is cell processes, I think. So these neoplastic cells are forming this eosinophilic material. So this is a neoplasm. It is sort of nervy in origin or nerve sheath in origin. And then, so there was actually some really fun cells somewhere in here. Let's see. I don't want to spend too much time because I've already spent too much time. I just wanted to point out that there's really significant cellular atypia. So these are giant cells with gigantic nuclei. So this is cytomegaly and karyomegaly. So there's quite a significant atypia in this neoplasm as well. So as I pointed out in the gross photo, this eye has very little melanin pigment in it, which is consistent with a blue eye. We have a little bit of melanin pigment around here as well, but overall, very little pigment. So I suspect that this is a schwannoma or a nerve sheath tumor, which are related to each other in the blue eye of a dog. So I think this is most schwannomas in the anterior uvea of blue-eyed dogs are quite benign. They're often very subtle and sometimes easy to miss because of how subtle they are, but this thing is not subtle at all. It sort of slaps you in the face like, hey, I'm a tumor and I'm malignant, at least histologically speaking. So I propose that this was a malignant nerve sheath tumor or schwannoma. We're just going to go right to the diagnoses now. Which makes it pretty unusual. So extensive malignant uveal schwannoma of the blue-eyed dog. Oh, and it seemed to extend around the optic nerve, which we don't need to go back to. So it's possible that the surgical margin is dirty in this case, and that it might continue to progress not only in the orbit of this dog, but also sometimes they progress up the optic canal to the brain, which is unfortunate. So there was also a corneal perforation, and there was intraocular inflammation with bacteria, which probably gained access through that corneal defect. And there was a cataract with possible lens capsule rupture. So as I was saying, most schwannomas in dogs are quite benign, and they never metastasize and are never life-threatening for the dog. They typically will cause glaucoma and pain, and often the eyes are enucleated because of glaucoma. But in this case, I am actually worried about this dog, the rest of the dog's health, because of how malignant and aggressive this tumor looked. So it's possible that this was going on for a long time. They didn't actually, let's see here. They did not tell us anything about the duration. It's possible that they did not know either. But it's possible that this unfortunate neglect of this tumor just let it continue to proliferate and get more aggressive. Any other questions or any questions here?
Nothing. Quiet chat.
Quiet in the chat. All right, cool. Then it's somebody else's turn now. Woo! Sorry. Nobody saw that.
Jump scare. April Fools. Don't look. All right. Let's see. I'm Dr. Jamie Miller, and I'm going to continue on with the next two cases here. First up is a kitty cat. This is a 13-year-old male-neutered Scottish fold cat who presented to the ophthalmologist back in August of last year for evaluation of blood in the right eye. That was first noted that morning. Previously, the cat had been diagnosed at the RDVM about a year prior with a cataract in that eye. And during their visit to the ophthalmologist in August, they diagnosed a cataract that was an early hypermature one with lens-induced uveitis, posterior synechia, and blood in the eye. Let's see. Then it seems like they did some rechecks, had some corneal ulcers that were superficial and kind of healed on and off for like the next couple months, and then and finally elected to enucleate the globe. The cat does have a history of being toxoplasmosis, IgG, and IgM positive, and the owner had reported that they had a suspected seizure in this cat about 10 years ago. Someone's pretty young, but nothing since. They do note that the other eye does have a focal inactive chorioretinal scar and a tiny dot of hemorrhage in the retina. So we did not have a gross photo for this case, so I grabbed a representative photo from our archives here. In our gross notes for our case, we noted that the cornea was kind of slightly cloudy with maybe a hint of an ulcer hair actually in the ventral portion of the cornea. We also noted that there was some posterior synechia. So here's our lens, here's our iris here. You can kind of look, seems like it's probably attached to the lens here. And that we noticed some fibrinous to hemorrhagic material sort of spanning the pupil, which I was hoping to capture kind of in this view here. We noted the vitreous was liquid and kind of thin with a bit of hemorrhage, grossly. And so we will take a look at what we got histologically. And to bear with me a little bit because I have two slides for this case, a superficial and a deep. And of course, the lesions are kind of spread out between the two sections. So we will make this work. So this is the superficial section. As we can see, we didn't quite capture all of the cornea, but that's not too much of a problem here. Here's the red kind of fibrinous material that was spanning the pupil that was seen grossly. We can kind of tell that the iris is a little bit adherent to the lens here. The lens is kind of artifactually fragmented, but we will definitely take a closer look at it because it's starting to look a little bit hypercellular. Here's a little bit of the hemorrhage, and they reported no glaucoma, and so the back of the eye looks pretty good. And also in the section here on the slide, we have an extra radial section of the globe, which we use to have an extra view of the iridocorneal angle and any other corneal lesions and stuff that we're looking for in the globe. So you can see that hemorrhage and tan fibrin material in the pupil there. We can see our iris being adhered to the lens capsule. You can see there's a little bit of blueness into our iris, and it's consistent with some lymphoplasmacytic uveitis. We can see some hemorrhage draining here in our angle. Here's some hemorrhage in the globe. You can see that our lens capsule is pretty wrinkled, and it looks pretty hypercellular here, and we'll take a look at that in just a second. I was just going to start over here really quickly in this extra section of the globe. We have a little area where the epithelium is kind of separated from the corneal stroma. And if we look at the epithelium a little bit closely, we can see that there's some little bit of eddy formations. And so our lens epithelium has, or sorry, our corneal epithelium sort of lost its way a little bit. So that's indicative of a true detachment of this corneal epithelium rather than artifact. So we do have an ulcer. So likely an indolent ulcer here. There's very minimal inflammation and vascularization coming into the cornea. Zoom back over here. And just to peek at our iris here, we have a lovely fibrovascular membrane on the anterior surface of our iris. It's coming along and crossing our angle here, and it's causing some peripheral anterior synechia. Again, some lymphocytes and plasma cells here in the iris stroma, so some anterior uveitis. The membrane is kind of pulling and tugging on the muscle here in the iris epithelium, and so we have some ectropion uvea. And if we follow along, we can see our hemorrhage kind of spanning our pupil space here. And we can tell that it's chronic hemorrhage because we have infiltration by macrophages that have both hemosiderin pigment and erythrocytes that are being phagocytized. So this has been going on a little while. And then if we start to look at our lens, again, the lens capsule is pretty wrinkled. We've got a fibrocellular membrane on the external surface of the iris and the lens capsule here. You can see it kind of plasters itself on the front of the lens. And if we start to take a look at these lens epithelium, there are way too many of them here. If we take even closer look, they start to get a little bit pleomorphic as we kind of scroll through them. They start to get really round. They get to be more spindle shaped. Actually, this is where I'm going to switch to my other slide because I really like the cells. The other one. So we can see they start to get quite pleomorphic here. We got lots of variation in the nuclear cell size. We got some multinucleated cells here and there. Ooh. And then we also can come across some mitotic figures that, of course, are going to elude me for a little bit here. Maybe some of these. Oh, here we go. Starting right here. A pretty bizarre looking one. And so that was a pretty consistent feature with these very pleomorphic and ugly looking cells. And so they were starting to look a bit neoplastic. And if we, sorry to jump back again, if we keep going around the lens to the other side, we see that there's also a similar population of these neoplastic cells on the external surface of the lens capsule. So our lens capsule is a little bit fragmented due to processing artifact, but these are definitely lens epithelium that have extended from inside the lens. So there is lens capsule rupture here somewhere. And we can see that we get to see some pleomorphism and some multinucleation here, and even a pretty weird looking mitotic figure as well. So we have neoplastic transformation of our lens epithelium. And so this is post-traumatic sarcoma in the eye of a cat. We call these early because it's not really forming a mass yet. It's just kind of inside the lens capsule and sort of lining the external surface of the lens. And then, as mentioned before, there's some hemorrhage here in the vitreous, and our retina and optic nerve were looking pretty healthy, good. So, as they said, no glaucoma in this eye, but good thing that they took it out because it's already starting to form a tumor. So, as I mentioned, early feline post-ocular or feline ocular post-traumatic sarcoma. Again, these are likely due to a traumatic event that causes lens capsule rupture, and they are originating from the lens epithelium that have undergone malignant transformation and form these really pleomorphic looking cells within and surrounding the lens, sort of thing. They can have the tumor development can have a kind of a protracted timeline with average of 7 years or so between the development of the tumor from the trauma, but can range sort of anywhere in between there. So it was just a nice little example of an early post-traumatic sarcoma in a cat. All right. Next up is we got some tissue from a 4-year-old male-neutered husky mixed dog. So this dog had the left eye nucleated about 2 months prior to what I'm about to show you. We did receive the eye from this dog. I'm not going to show it. It was a husky that presented with bilateral symmetric panuveitis in both eyes there with secondary glaucoma with the presumptive diagnosis of VKH-like disease or canine uveo-dermatologic syndrome. The globe that we got had sort of very minimal inflammation of lymphoplasmacytic panuveitis with the melanin-laden macrophages. There was also ulcer and cataract, and so while it was maybe suspicious for UDS, it was maybe not specific for, but cautioned with all the other clinical findings that it was probably UDS. They were already treating this dog before we got the eye as well. So that might have also affected the inflammation that we're seeing in the eye. And I didn't think it was going to show up very well, so I'm not going to show the eye. So about 2 weeks after the enucleation, the dog presented with an orbital infection that developed. So we can see our previous enucleation site here. We can see a couple like little draining tracks. We can see stuff coming, exuding out from the surgical site. They did culture meth-resistant Staph pseudoinomedius that was originally responsive to some oral medication, but the skin never really fully closed and it sort of developed a chronic open wound. So they decided to go in and do an explore and excise some of that tissue. And what we received was about 21 pieces of some brown soft tissue, mostly didn't have any anatomic orientation to it, aside from a couple pieces of haired skin that did look like it had cavitations and draining tracts communicating with it. After looking at this case, I did go back and take a picture of the contents that we received, and this is what it looks like. So it's kind of this tan, looks a little bit red in here. I teased it apart a little bit and it maybe is looking a little bit ropey here. And that will come into play. Look at this histological. All right. I'm going to start with this section of haired skin that we received from the previous surgical site. So we have haired skin here, we have hair follicles. Then we can see here where the epidermis gets really thickened and then it's suddenly abruptly disrupted. And there's this lovely little tract that extends down through the dermis and the subcutis all the way down to the margin here. And you can see that there's fibrovascular tissue kind of lining the underside of the haired skin. We'll take a little bit closer look at that. We've got some cystic follicles kind of at the periphery of these tracts. We see some multifocal inflammation, and then again over here, kind of another area where there's at least partial tract formation here that was sampled, as well as some other material here that we will take a look at in just a second. So these draining tracts are lined by a lot of fibrovascular tissue that's edematous, and it's filled with lots of neutrophils. And some macrophages here and there, smaller numbers of lymphocytes, plasma cells, and even some hemosiderin pigment-laden macrophages as well. If we take a look at kind of the more superficial inflammation, it is pyogranulomatous, kind of like Dr. Shaw talked about in her case. And that inflammation is often surrounding these keratin flakes and debris. So we've got some furunculosis. We've got some multinucleated giant cells in here coming in here trying to clean some stuff up. Here is a free hair shaft. So we just have some evidence of like post-surgical things that can happen with ruptures of hair follicles and such. And then interestingly, as I said, towards this other draining tract, we started to notice this like amphiphilic material that was often surrounded by the macrophages. Here's some of that material here. It was kind of variable in size and kind of very angular looking. Some of it was smaller, some of it was a little bit bigger. There's a few little bit of it here. Then the bigger one that was a little bit more fun to look at, very geometric. Let's see if I can get it to polarize it. So let's see if it'll. So it is like somewhat kind of partially birefringent. It's not consistent, like smoothly birefringent throughout the entire stuff. I'm not really sure what this was. We did think about, maybe some resorbable suture or something, but it seems very large and kind of irregular for that. So not really sure what this material is. But it looks different than what the rest of the tissues look like. And the rest of the material from the orbit, you can see that we just got random pieces of some hemorrhage and some cells And if we go take a closer look at what's going on here, we can see that what's here are just tons of macrophages and multinucleated giant cells. And they're having a party around these refractile bits of foreign material here. So you can see all these linear pieces. And then again, for some fun here, so pretty. And I leave that there and I back out. We can see just how extensive this material is in the stuff that we received. So that was most of the content that we received from the orbit was this refractile and birefringent material. Again, more diffusely birefringent and looks a little bit different than what was in the haired skin. This with the history of previous surgery and all the granulomatous inflammation associated with this material. This is likely gossypiboma or some sort of textile type material, textiloma, if you will, that was in the orbit.
Do you guys know what Gossi refers to? Cotton. However, not many surgical sponges are made of cotton anymore. Oh, sorry.
Yeah, no, that's
Carry
fine.
on.
No, yeah. Dr. Shaw was just saying that the Gossi part of the gossypiboma refers to cotton material, but maybe not all of the more current surgical material is made of cotton anymore, which is maybe why textiloma
Or unintentional retained foreign body.
unintentional retained foreign body.
Some cottonoid.
Cottonoid. Yes.
Someone responded and said, I've moved to textileoma myself.
Oh,
So
there you go.
there
Lovely.
you go. Or nylopiboma.
Nylopiboma.
Something like that. Nylopiboma.
This is synthetic gossypiboma.
Yeah, so just a really interesting post-surgical complication in this dog. So, and lots of fun to look at.
Somebody else said synthaloma.
Synthaloma.
Yeah.
Yeah. All right.
Just retain foreign object in RFO.
Yeah.
Retain foreign object. Yep. All right.
Right, this is Kelsey. I'm going to be going through the last two cases. Our first one being the eye from a 4.5-year-old female spayed domestic long hair with probably the best name I've ever heard. I'm sad that I can't provide it to you all, but imagine a really, really good pet name. Okay, so the history received for this eye is that it was previously smaller when they first saw this cat. And now it has darkly pigmented tissue protruding from the globe, along with multiple areas of prolapse through what was suspected to be cornea. The clinician suspected a traumatic injury years prior due to a focal area fibrosis visible in a photo of the cat from adoption. And they have concerns for feline post-traumatic ocular sarcoma. And the other eye is normal. And this problem has been going on for maybe 3 to 4 years. So it sounds like since they adopted this cat. Okay, so here is our gross hemisection of the globe. Our optic nerve head is somewhere down here. It's a little bit hard to see just because there's some material covering it. Up at the top is what is supposed to be cornea. Maybe at the edge here, we can make out some normal-ish cornea. Perhaps we have our limbus right here. We can see some normal sclera. And then there's the areas where that cornea kind of drops out. Maybe we pick up some corneal-like tissue, kind of again, as we go to the periphery here, back to the limbus. Our uveal tissue is heavily distorted, at least in the anterior segment. So we have some ciliary body here, and then our iris is plastered kind of diffusely across the posterior aspect of what should be cornea, and maybe is prolapsing through in some areas. So this is what we call broad anterior synechia. So there's no anterior chamber at this point. It's totally collapsed due to that synechia. As we move back, you'll notice that there really isn't any obvious lenticular tissue here. It's kind of an empty space. And then we have this tan tissue that's extending over the ciliary body, maybe also over the choroid. This could also potentially be detached retina as well. So like right here, we have some retinal detachment, this billowing material. Okay, so we will move on to the histology.
Did we fit that into a mega cassette?
We did.
Wow.
Yeah. It's actually, I feel like the gross image is kind of deceptive. It's not like the biggest eye. I know how to do this. Here we go. Let's start with our subgross. Like it's not huge. For a cat, it's quite large. Okay. So here's our subgross, and eventually I'll actually get it focused. I'm never very good at this. So we have our cornea up top, or which should be cornea, and then we don't have the optic nerve head in this section, but it should be, yay here. So similar to the gross photo, we have some areas where we can make out some normal cornea, at least corneal stroma. Here is our iris leaflet. We have that anterior synechia, and then areas where that stroma drops out, and we just have iris. And then maybe we pick up some normal corneal stroma again as we move around. There's this kind of funny distortion at the limbus here too, where this is kind of like inward, I don't know, inward like tongue of limbal stroma. I think just due to, this distortion and thinning of the corneal stroma up here is just causing that like force to move it in. Then we have our ciliary body. It's kind of a funny section. So we see like a ton of ciliary body plica. And there is this collagenous tissue that's lining that ciliary body. And then this very deeply basophilic material, which we'll look at more closely. As we move back, we have our retina. It is truly detached. And again, we can look at that a little bit more closely. So let's actually put it on the stage. Okay, so we've turned the eye. So now the cornea is to the right, posterior segment is going to be to the left. We'll start kind of at our normal-ish edge. First thing to point out, at our junction of the bulbar conj and cornea, we do have a peripheral symblepharon. So we have this little fusion of the conjunctival epithelium and the corneal epithelium, kind of right at the fornix here. There's this kind of cleft that's artifact. So this is truly a symblepharon. And let's see, right at the peripheral cornea, we do have some normal corneal elements. So we have our corneal epithelium, stroma. It is vascularized, but we at least have some normal stromal collagen, and then Descemet's membrane. As we move, back out one. As we move more axially, we do have some attenuation of the corneal epithelium, and more vascularization, maybe some inflammation. It's kind of just mixed, non-specific inflammation. And then we have this loss of Descemet's membrane. And that's where our anterior synechia starts. So we just have a fusion of the iris with the posterior corneal sclera, or corneal stroma. And we have entrapment of some melanin-laden cells, so probably just from the iris. And as we move this way, kind of right where we lose our corneal stroma, we have replacement of the stroma with this kind of disorganized fibrous connective tissue. So we do have some stromal fibrosis. And while we're here, I'll also point out there's a little bit of lymphoplasmacytic inflammation in the iris, so mild anterior uveitis. So then at this juncture, we have total loss of that corneal stroma, and we just have iris that's being lined directly by corneal epithelium. So likely this all represents a total loss of our cornea, prolapse of that iris through that corneal defect, and then re-epithelialization over the iris. So kind of a pseudo corneal stroma, if you will. And as we kind of go back to the other side of the cornea, we start to pick up maybe some more stroma. Some of this looks like fibrosis, but we can kind of keep following it peripherally. And again, kind of pick up a little bit more stroma here. There's still that anterior synechia. We have more peripheral symblepharon here at this fornix. And then kind of at this weird little area, we pick up Descemet's membrane again. So pretty large discontinuity in Descemet's membrane too, to accompany this broad anterior synechia. Okay. As we move over to our ciliary body, as I mentioned, there's this, let me do that, there we go. There is this dense collagenous tissue that's broadly lining the ciliary body, kind of causing this distortion of the plicae. There are some vessels within that tissue as well. And embedded in that collagenous tissue, there's also this mineralized woven bone, which in some places has areas reminiscent of bone marrow. So we have this intertrabecular space that has some adipocytes and these kind of small little cells, potentially hematopoietic cells. And if we look more closely away from the bone, there's this kind of coiled up basement membrane-like tissue. Some other areas, here's more of it, which given the location is probably a fragment of lens capsule that's embedded in this collagenous membrane. It's discontinuous and there are no lens fibers, so it's probably a lens capsule rupture. Looking around, we don't see any evidence of feline post-traumatic ocular sarcoma. We do have a lens capsule rupture, but we're not seeing the sequela of that. Everything looks pretty well behaved and non-neoplastic. And as we continue to move on, we can go over to our retina, which is truly detached. And there are variable degrees of atrophy. Some places it's more of an outer atrophy. We still have our ganglion cell layer with loss of the inner and outer nuclear layers. In other areas, we have a more kind of full thickness retinal atrophy. And like any good young cat with a retinal detachment, there is hypertrophy of the retinal pigment epithelium. It's also in some areas somewhat hyperplastic too. We'll just see a little bit more of it starts to kind of pile up, which younger cats love to do when their retinas are detached. Here's probably a better area of that retinal pigment epithelium. It's non-specific, just sequela of this retinal detachment. All right, and we don't have the optic nerve head in this section, but it was not remarkable. It was just distorted by the detached retina, so nothing too exciting to show there. All right, I will move over to our diagnoses for this. I can chat about the case. So the findings in the anterior segment loans itself to a couple different possibilities. The total loss of the corneal stroma with that iris prolapse and re-epithelialization over the iris is most suggestive of feline early life eye disease, also known as feline early life ocular disease, which is a condition that's essentially everything I just said. So total loss of stroma, we have that iris that's being lined by corneal epithelium. There is a paper going over this condition, and the favored mechanism for that constellation of lesions is viral disease, potentially causing a total corneal destruction. In a good chunk of cats that was in that case series, they did have a symblepharon, which we typically attribute to viral disease, most commonly herpes virus. So the thought is that it could be a herpes viral entity. Though we have also identified a subset of cats who are herpes virus negative by PCR and positive for calicivirus, so potentially other viruses could also be implicated in this condition. The paper also mentions trauma as a possible mechanism, though it seems viral is the favored mechanism. And in our case, we do have some lesions that could be consistent with trauma, either as part of the feline early life eye disease or concurrent with that. So that would include the lens capsule rupture, as well as the diffuse retinal detachment and atrophy. So in this case, it's hard to pinpoint exactly what the precise inciting cause of this disease was. Likely did happen at an early age, corroborated by the fact this cat has had an abnormal eye since it was adopted at a young age. Other things, there was the osseous metaplasia, so that bone formation within that collagenous membrane over the ciliary body, which is something we commonly see, especially in young cats with lens capsule rupture and just chronic eye disease. It did not appear to be neoplastic, so just a reactive bone formation in the eye. And that I think is all I have for this one. I don't know if there's any questions in the chat. All right, a few minutes to do this one, which is pretty short. So this one is going to be a piece of conjunctiva from a 1.5-year-old male castrated domestic short hair. The history we received was that there was moderate upper eyelid chemosis in the right eye, which is the eye we're seeing here, and then mild upper eyelid chemosis in the left eye. And the pet, presented just for this upper eyelid swelling. And there is some history that I will withhold for the time being. And we will go to the histology on that globe. So we just got little bits of conjunctiva. Just
move around, just show all these little bits. And a lot of these, we do have some structures to help us orient ourselves. So we'll go over here. Let's go this one. So we do have conjunctival epithelium in our substantia propria. What's causing that swelling that was clinically described and seen in the photo is this cellular infiltrate. It's fairly well demarcated in areas. It's unencapsulated and it is densely cellular. It's kind of hard to make out, but there's a lot of little dip dots. So those are the nuclei. And these cells are forming these variably sized lobules. It's kind of separated by these collagenous septa. And there's a little bit of mineral sometimes within these areas. We'll just go to near my dots. A little closer. Then closer. So this is a homogeneous population of cells. And they're round cells. We can kind of make out their borders. They are variably sized. And they have this kind of weirdly vacuolated cytoplasm. Nuclei are somewhat uniform, so they're round to oval. There's coarsely supple chromatin, and then 1 to sometimes 2 prominent nucleoli. And not much in terms of mitoses. There isn't very much nuclear atypia. As I said, it's pretty uniform. So these are actually macrophages. This is a histiocytic response. And let's see if I can find, I have some favorite cells to show. And there are some just wildly multinucleated cells in here. So I can't even count how many nuclei are in here. Those are kind of these funny structures. Not quite sure what those are, but yeah, some kind of fun cells here. We have a 60X. So what's of interest here? What is causing this histiocytic response? And if we look a little bit closer, there are these kind of faint structures within the cytoplasm, really hard to see. But they're round, they're tiny, so maybe 2 to 3 microns in diameter, and sometimes they're surrounded by a little bit of a clear space. So to help further elucidate them, we have a GMS stain. And at first I thought this stain failed. I was like, oh, it's so dirty. There's so much background staining. So we use a stain to stain fungi most often. So all of these round structures are fungal yeast. We can make them out a little bit better. So we can see they're round, aren't really many of their defining features about them. There's just a ton of them, filling up all these macrophages. So intrahistocytic fungal yeast of this size with this morphology is most consistent with histoplasma. And this is just a robust histoplasmosis. Really crazy. So the history that I withheld is that this cat had been treated with itraconazole for presumed histoplasma, though the diagnosis has not been confirmed, which we can provide for them in this case. Apparently he had a positive systemic response to the drug, but the swelling hadn't changed in this case. So pretty wild, even in cases that are untreated, I feel like we don't see this number of histoplasma. Usually they're a little bit harder to find. And the fact that this cat has been treated does make me wonder if there is some sort of immune compromise or something that's causing such a florid response here. All right, so with our 2 minutes.
It looked like a well-behaved tumor at low mag.
Right? Yeah.
This is an epithelial tumor. I'm like, wait a minute.
I know, at low power, I'm like, oh, what am I going to call this? And I got much closer, I'm like, oh, wait. It's kind of bizarre. I feel like usually we'll see other inflammatory cells, something, but it's just sheets of histiocytes. So kind of a weird one. So histoplasmosis, typically when we see in the eye, it's usually an ocular manifestation of systemic disease. In this case, we do have bilateral conjunctival involvement, and it sounds like there was maybe systemic signs as well that just weren't provided to us. So presumably this is just, a manifestation of systemic disease in this cat. So cool. That's all I got for this one.
All right.
Anything in the chat?
Nothing in the chat.
All right, great. In that case, we'll finish up rounds with 1 minute to spare. And we'll see y'all in 2 weeks. I don't remember how to do this.